Right, good afternoon everyone. Can you all hear me okay? It seems a good start point. Jolly good. I'll just let Linda get on with that.
Yeah,
I'm very aware that I stand between you and lunch and that I'm going to be talking about numbers. So I just want to know what I did to offend you, Linda. Yes. It was a sort of chuckle of acknowledgement, I thought there. I've obviously done something. Anyway.
no.
How are we doing?
You get your own stick. Yours wouldn't go on the others for some special reason. You're
Oh,
special.
I'm special, as my mother always said. Right. Are we there? Well, anyway, just to introduce myself, I'm Richard Hamblin. I measure stuff at the Commission, and one of the things that I'm charged with is answering the question of whether New Zealand's health system is any good or not.
There.
Marvellous, thank you
There
so
you go.
much.
And just
Thank you.
push that button.
Thank you. So one of the things I'm charged with is saying whether the New Zealand health system is any good or not. And that's a reasonably challenging task to do, especially because we're sort of endeavouring to do it in a sort of relatively economical way, efficient way. And you end up with a position where what you're trying to do is talk about the quality of what is 10.5%, 11% of the national economy in 20 to 25 figures, 20 to 25 indicators, which is quite a tall ask. And the approach that we've taken is to sort of think, what are the things that we would want to measure? What are the things we want to know about? And drawing, I think I could see you've had the triple aim idea, that triangle with the population, health, the individual. Good, you've had that. Taking that down one step lower is something that the Institute of Medicine in the United States suggested, which was a six-fold way of viewing the world, which they called STEEP, sort of steep with an extra E, so STEEP. So safety, timeliness, the ability to get into care, efficiency, effectiveness, in other words, does the care actually do any good, equity, and the final P, patient-centeredness or patient experience. Now, for about 18 months we've been working on this particular way of thinking about the quality of New Zealand system. And we put stuff out, it gets out there, it says its piece, but the big hole is the ability to say something sensible about patient experience. And that, I think, is to some extent a degree of history in there. New Zealand, for a long time actually, from the early 1990s, used something called its Consumer Satisfaction Survey. And that existed for a fair whack of time. It was abandoned in 2011. I think, I know there are people in the room who were closer to this decision than I was, but my understanding was that you had two fundamental problems with it. One is the concept of satisfaction as opposed to experience is something that increasingly the literature and the evidence suggests is not necessarily the most helpful way about thinking about people's experience. Satisfaction can reflect a lot of things which actually have little to do with the experience of the service and some outside preconceptions and so forth. Also, one of the real problems was that the satisfaction survey had run so long that we got to a position where everybody was 95, 98% satisfied, which kind of didn't ring entirely true and kind of pointed to the fact that the survey as a tool had perhaps outlived its usefulness a little bit. So we found ourselves at the beginning of 2012 with no clear data source for answering this critical question about quality of care. And so, at the same time, we were very aware that a number of local services had been very astute about this and had got forward, realised the importance of understanding the quality of care. And I identified a number of developments which were of value. So we were having people with real-time feedback from their wards collected on iPads. We had people experimenting with this idea called the Friends and Families test, which no doubt we'll speak about in a moment. We had others who'd built in really quite powerful systems that allowed an ongoing monitoring, an ongoing surveying of patients, and the ability to drill down right to individual wards and understand the position at a very local level. So we had to somehow draw all this together, and really for the last year or so we have been working in this area. And one of the first things we did was to look at, well, what does the evidence suggest is a good way of thinking about, of conceptualizing patient experience. And there's been, I guess, about 20, 25 years of reasonably well-researched, reasonably well-evidenced academic work in this field. And a review of this and a review of what's being done globally, because this is a global issue. New Zealand is, alongside the rest of the world in trying to work out how to get at these issues. And looking at that, sort of four big themes, what we might call domains of quality, domains of patient experience emerge. And these are shown on the slide in front of you. Four of them, really. The first, communication. How well am I listened to? How well are my options explained? Do I get an explanation of what's going on in ways that I can understand? When I have something to say, is it listened to, is it taken on board? It's that two-way communication between the consumer, between the patient, and the person providing care. The second of these, we've used the word partnership. We might have used the word engagement, we might have used the words involvement. That's about how individuals and their families and whānau are actually involved in making decisions about care, in actually delivering the care, about getting hold of the services that are needed. The third of these is around the idea of coordination of care, and that's really about how different services work together. And I think that was very interesting, actually, in the question that Lynn just got asked about what about the people who don't enter the service. And I think increasingly this issue of integration across boundaries will become an important one to understand. And the final of this is perhaps the slightly more technocratic element of it, the physical and emotional needs of the patient or the consumer. So things like pain management, things like help with toileting when needed, things like being treated with dignity and respect. So once we had identified these as the outlying or the key areas that we thought were important to look at, we did some testing of this, and it seemed to be, you could have some argument about exactly what you called things, exactly where you drew the boundaries on this, but this seemed to be a fairly reasonable consensus that this got to the heart of things. So then the question was, how do you find out about it? What's the way of doing it? And again, we looked at what is available. We were keen not to sort of reinvent wheels and spend 3 years developing the perfect survey set. Well, we didn't know anything about what was going on. So we did look at what had been done overseas and elsewhere. And there was a range of options that we could take, but we've been able to get hold of a set of questions produced by an organisation called the Picker Institute. The Picker Institute were a charitable organisation in the United States that went across to Europe. They run this sort of thing actually in most of the rest of the world, and our colleagues in Australia are also picking up on this sort of thing. And what's rather nice about it is you actually have a library of about 250 questions. So it's a big, broad thing. Now, we had a general view that a survey that was 250 questions long probably wasn't the solution. However, we thought within that there was probably enough of some reasonable and reasonably well-tested questions that would fulfill our needs. And we've been through a process over the last sort of 6 months or so of sort of really quite rigorous testing of these questions with patients groups and groups of patients around the country. And after a sort of process of iteration of slight changes of wording so that they're acceptable and understood in a New Zealand context, slight alterations, dropping some, bringing some others in, we've come to a position now where we have around about 20 key questions which we've put together in a tool which answers, we think, some of these issues. Those questions are actually designed so that we have 2 or 3 questions underpinning it, 2, 3, 4 questions underpinning. a request that people rate their experience between 0 and 10, where 0 is really don't want to go there, 10 is as good as it could be imagined. And critically, for each of these domains and overall, provide that free text, the capacity to tell your story, to give the narrative. And like Lynn, we had exactly the same experience. The importance of that to consumers, to be able to say in their own words what happened to them, and their understanding of their experience and their reflection on their experience, was a critical thing to bring in. So putting these sort of three elements for each of the domains together seems to us to be quite a strong way of doing this. You get some narrative, you get a rating, and then you get some, if you like, objective, specific details together. And those three seem to us to be the basis of a good tool. Now, I'm sort of aware that if I say 20 questions, there's a sort of panic about, sort of asking people to sort of talk away for an hour. What is quite interesting is that we've actually tested this, which I'll come on to in a moment, as part of a sort of quasi-live system. And what's quite interesting is that the recording time, or the time that we've seen people needing to answer the questions, is no more than 6 minutes. So it's not a major, difficult, write an essay and feel, as an hour of your life has just disappeared. It does seem to be something that can be answered quite quickly. However, the danger with this is that we've built a rather nice tool that we in the centre can then go away and sort of produce some rather clever stats once every quarter, and it's published maybe, and the DHBs have a look at it and respond or not, as the case may be. However, what we do know from some of those pieces of work that were being undertaken is that there's a real power in these if they are used continually, and they are used to drive improvement at a local level rather than be purely about some sort of quasi-accountability. And with that in mind, one of the things that we wanted to do was to create a national system that was as easy as possible for DHBs to use, so that rather than putting their resources into envelope stuffing, they're putting their resources into responding to the results and improving their services. So what we've been doing really for the last 3 months is what we're calling a proof of concept. We've been working on a sort of quick and light scale of building a system which requires no more than the DHB identifying who the patients discharged within certain parameters were within a 2-week period, and then everything else is administered by professionals who know what they're doing in the survey space. And what comes back is an as-live dashboard that tells the DHB how they're doing with their patients. Now, this has been an interesting experience to do, something that we've done with a degree of alacrity, certainly. But what we've learned is slightly how to do it. We've learned that it can be done, and it can be done at a reasonable price. And the good news of this is, based on what we learned through the proof of concept, is we set a contract out of tender about 6 weeks ago. We actually chose our preferred provider last week, and we should be signing the contract in the next 10 days or so. So we actually are in a place from 1 July, this system will go live. With probably the first collection of data for the national figures in August. And actually, in many ways, it deals with the similar sort of set of issues as Lynn spoke about. These are a couple of mock-ups of this. This was the proof of concept system, and the final version we'll get will be much prettier than this. It'll be rather sleeker and rather sort of quicker. But what you see here is at a top level, you see the ratings out of 10 for those 4 areas. And then we can drill down in and actually see the answers for each of the questions that fit underneath that. The Bay of Plenty reports, first of all, my thanks to Bay of Plenty for being one of our guinea pigs for the proof of concept. But this was actually entirely about addressing that question that Lynn raised about what do you do if there's feedback, if people want to tell you something. And what this system will do is provide alerts to the DHB. There is somebody who wants to talk to you about their system. And actually, if I'd clicked on behind this and printed it, you'd have seen the names of the people who wanted to talk further with the DHB. which is why I didn't click on it and print it out for you to look at, obviously. So that's where we're going with this. We'll be running live from, as I say, from the 1st of July, with data really running from August. And DHBs have a choice. The minimum is to do this once a quarter, so that we have a sort of, if you like, a national picture, which we shall publish. But the system is designed so that at no extra cost, they can do this every 2 weeks. So there's a constant updating of these data. That dashboard will be seen live, so as somebody puts their, gives their answer, certainly by first thing the next morning it will be available on somebody's desktop. So we think it is a bit of a step forward in some of this, and trying to move to a position away from everything goes into a black box in the centre and we do some number crunching on it that you don't understand, to much more of about here's something that can be done, used locally to deliver. So, aware of lunch, I'm just going to finish very, very quickly on why I think this is important. So why I think it is so important to fill this gap, why have we spent this time doing it? And it's not in any way a matter of tokenism. I think one of the things that I'm very aware of is that most of the other measures that we use to look at quality have an inherent technocratic quality about them. They are about doing the right things to avoid some harms, or they are, constructions of mortality rates which, are accurate and scientifically correct, but actually quite kind of one step removed from people's experiences in many ways. And I think the danger is, if you don't look at patient experience and put it at the centre of what you do, you end up with, I suppose, I don't mean this flippantly at all, but you end up with measures which announce that the operation was a success even if the patient died. And there's that sort of sense of, we can show that we're doing all the right things and we can show that we are statistically as we expect, even though the experience of the patients may be dreadful. So making sure you're putting that in seems to me very, very important, and very important for technocrats like me to remember. However, and I think just to add to this, what is quite interesting, and this isn't a sort of academic exercise, looking at other jurisdictions when people tell the story of services that failed badly and where scandals happened, what is very interesting is very often the technocratic measures looked okay. And what was not heard was the voice of the patient, the voice of the user, the voice of the consumer. And that's why we are determined to make this work and make sure that the voice of the user is absolutely heard, and that we build a system that enables that to be done straightforwardly. And at that point, I'll get out of the way of lunch.